Hi, everyone. Welcome to the Lymphoma Research Foundation's Ask the Doctor About Lymphoma program. My name is Hope Avalone, and I'm the Program Manager of Patient Education here at LRF. We'll get started very shortly, and I'll give everyone just a moment to log on and get settled. But while we wait, I wanted to go over a few features of today's program. So first of all, everyone is muted automatically upon entering the program, and that's just to reduce any feedback or other sounds while the speaker is presenting. And I also wanted to review the buttons at the bottom of your screen in the center. We ask that you use that first button, the chat function, to ask about any tech issues that you might come across today. And if you do have a question that you'd like to ask to the speaker, you may do so in the Q&A box, and that should be the third button at the bottom of your screen. And any question you submit through the Q&A box will be able to be made anonymous. We do anticipate a large number of attendees for today's program, so at the end of the presentation, we'll be taking questions from the Q&A box, and we'll aim to address as many of those questions as possible. And we ask that you try to make those questions as general as possible, so as much of the audience can benefit as possible. But for now, let's get started. Welcome everyone formally to today's program. Thank you again to each of you for taking your time to join us on today's Ask the Doctor About Lymphoma program for newly diagnosed patients featuring Dr. Kamdar. My name is Hope, and again, I'm the Program Manager of Patient Education here at the Lymphoma Research Foundation. We know that access to expert disease information is so important, and so we're thrilled to be able to bring you this educational program today. At the Lymphoma Research Foundation, our mission is to eradicate lymphoma and to serve those touched by the disease. The Lymphoma Research Foundation is the nation's largest nonprofit organization devoted to funding lymphoma research, as well as providing patient care and comprehensive lymphoma education for patients and healthcare professionals alike, and that's all using input from our scientific advisory board. And in addition to our patient education programming, LRF also focuses on our research portfolio to help fund the future of lymphoma care. And LRF also offers a variety of educational resources and support. So in addition to our live educational programs like this one, we do have subtype and treatment-specific fact sheets and guidebooks, as well as a mobile app. And I specifically wanted to highlight our Lymphoma Support Network, or LSN, which provides a one-to-one peer support program for people with lymphoma and their caregivers. We do have volunteers available to offer words of encouragement and understanding, and just to give others strength to meet the challenges that they might have to face during this time. So to find more information on any of these resources, please reach out to our helpline at 800-500-9976. This program is made possible by grants from our sponsors. We do so greatly appreciate their support of our Ask the Doctor programming. So what can you expect from today's program? Today, you can expect to hear from a lymphoma expert about the diagnosis of lymphoma and updates in treatment. There will also be an adequate time for a question and answer session at the end, as I've mentioned. But finally, I'm so honored to introduce our speaker today, Dr. Manali Kamdar. Dr. Kamdar is a hematologist and oncologist at the University of Colorado, where she's also the Director of Lymphoma Services, as well as an Associate Professor of Medicine. And we're so pleased to have her here on our program today. So without further ado, Dr. Kamdar, I'll now turn the talk over to you.
Thank you very much to LRF for this generous invitation. And I'm so excited to be speaking with all of you. So I'm going to quickly go ahead and share my screen. So I have been tasked today with discussing just an overview of lymphoma. And it's an umbrella topic. But what I do hope to cover through this 1.5 hour discussion is the incidence and subtypes of lymphomas, the clinical features, diagnosis, multiple treatment options, and some of the most promising therapies that are available. Especially over the last 4 years, there has been a huge splash with regards to chemo-free options. And it makes me very, very hopeful for everyone who is here today, as well as for all lymphoma patients, because the incidence and prevalence being high, we also want to make sure that the cure rates are also high. So let's start off with the basics. As most of you know, lymphoma is the most common blood cancer. It's actually the 5th most common blood cancer in the United States. It encompasses more than 100 different subtypes, which I'll go over in the next slide briefly. But it typically is a cancer that originates from what we call the lymphoreticular system. This encompasses lymph nodes, blood, spleen, thymus, tonsils, bone marrow. Lymph nodes are basically filters that destroy microorganisms, and they comprise of lymphocytes, which are typically 3 types: B cells, T cells, and NK cells. These are basically the Army, Navy, Air Force of your body. The job of these cells is to fight off infection and inflammation. Normally, there are switches that tell these lymph cells to grow, and when their job is done, they die. So they typically grow, they die, they grow, they die. However, in patients who develop a lymphoma, these switches become aurai. And when that happens, they only get a switch that tells them to keep growing. They grow into small islands, which in medical terminology is called a lymph node. You may or may not have noted a small lymph node pop up at the back of your ear if any of you have had the flu. It goes away once the flu is gone because that's the lymph node trying to fight off the flu. In lymphoma, these lymph nodes typically do not recede in size. They either stay the same size or they gradually increase. In terms of the 8 specific incidents, we typically divide lymphomas into non-Hodgkin lymphoma and Hodgkin lymphoma. But when we look at the ages where these 2 major subtypes of lymphomas are primarily concentrated, you can see that in patients with non-Hodgkin lymphoma, the age range starts to increase in incidence beyond 50. And as you can see, this is an age group between 60 and 80 where we see a lot of patients with non-Hodgkin lymphoma. That doesn't mean that somebody in their 30s or 40s cannot be diagnosed with non-Hodgkin lymphoma, but it's typically not as common. On the other hand, when we talk about Hodgkin lymphoma, the second type of lymphoma that we typically see, it has what we call a bimodal age distribution. So we see it in the younger patients, and then we see it in the not so younger patients. So when we look at the younger patients, we see patients with Hodgkin anywhere from the age groups of 15 and 30, and then there is a second peak between ages 60 and 80. As many of you may be aware, Hodgkin lymphoma is a highly curable lymphoma. However, the fact that it actually presents with this bimodal predisposition really ends up causing a little bit of challenge with regards to, say, for example, younger patients. You have a high cure rate, but with the therapies that we give them, we want to make sure they don't have any long-term toxicities. On the other hand, elderly Hodgkin lymphoma patients, we want them to get to that cure, but we want to make sure that the therapies that we give them are actually less toxic, so that their quality of life is maintained. So these are the 2 challenges that we typically look at when we talk about management for patients with Hodgkin lymphoma. A lot has been talked about and is continuing to be researched with regards to causes of lymphoma. What actually leads to lymphoma? And I can say that there are risk factors, meaning there may be an association. However, a cause and effect is not something that is always as outlined clearly in lymphoma. Say, for example, in the world of lung cancers, we know smoking causes lung cancer. That kind of a cause and effect doesn't quite exist in lymphoma, but there are possible risk factors. For example, certain infections can predispose a patient to developing a subtype of lymphoma called marginal zone lymphoma, also called MALT lymphoma. For example, H. pylori is a bacteria that can cause stomach marginal zone lymphoma. And therapy for H. pylori is antibiotics. And once we give antibiotics, it typically causes shrinkage of the tumor. Similarly, other risk factors that can cause lymphoma are autoimmune conditions like Sjogren's, Hashimoto's thyroiditis, Immune deficiencies, patients who go through organ transplants, they have to be on chronic immune suppression. Patients who have rheumatoid arthritis, they have to be on chronic immune suppression. Again, that does not really mean that everyone who gets immune suppression develops lymphoma. As a result, a lot really remains to be continued to research within to be able to figure out the etiology of lymphoma. Very, very rarely does lymphoma have a hereditary component. And when I talk about hereditary, it typically means the mom has it, the child has it, the cousin has it. And that kind of a hereditary component is again being researched, but it has been seen in certain indolent or chronic lymphomas like CLL and follicular lymphoma. With that said, let's deep dive into lymphomas. This is called the WHO classification of lymphomas, which helps us understand what is the subtype of lymphoma that our patient has. This is really not meant to be readable, but this is meant to really outline that there are nearly 85 different subtypes of lymphomas based on the iteration that you're looking at. In 2022, there were 2 different iterations of the classifications of lymphomas, and I think the count reached up to 100. Regardless, I think what I'm really trying to highlight here that not all lymphomas are the same. As a result, it's really important to get to a specialist. To get to somebody who only sees lymphomas is really helpful for even a second opinion, to be able to outline what are the nuances with regards to management of lymphoma. When I look at 100 different subtypes of lymphomas, I like to keep it simple. And in my mind, when I see someone with lymphoma, I really want to know which bucket does that patient fit in. So primarily, lymphomas are divided into either Hodgkin lymphoma or non-Hodgkin lymphoma. About 8,000 patients are diagnosed with Hodgkin every year. On the other hand, 85,000 patients are diagnosed with non-Hodgkin lymphoma every year. Of the non-Hodgkin lymphomas, they are primarily further divided into either B-cell non-Hodgkin lymphoma, comprising 85% of the bucket, or T-cell non-Hodgkin lymphoma or NK cell lymphoma, comprising 15% of the bucket. Now, T-cell non-Hodgkin lymphoma is a rare entity, and I can trust to say that there are multiple research clinical trials that are ongoing within T-cell non-Hodgkin lymphoma. In the past, the outcomes were not that good. They were very sobering. Today, we continue to develop novel treatments, and these therapies are definitely filled with more promise, but we have a lot more work that needs to be done within T-cell non-Hodgkin lymphomas. Concentrating on B-cell non-Hodgkin lymphoma, which comprises of about 85% now, they are typically divided into 3 buckets. I look at it in form of aggressive lymphomas. So fast-growing patients are typically very symptomatic. They have fevers, the loss of weight, abdominal pain. They have large, bulky lumps. Usually, chemotherapy is the way to go for patients with aggressive lymphoma. And the typical examples are diffuse large cell lymphoma, primary mediastinal B-cell lymphoma, Burkitt lymphoma. On the other hand, indolent lymphoma, which is the second bucket, is actually a slow-growing lymphoma. These are primarily chronic conditions. So we typically tell our patients that you're going to live with this condition for a very, very long time. As a result, the therapies that we give are primarily aimed towards not only putting the lymphoma in remission, but also maintaining quality of life. That's extremely important across the 3 buckets, but even more so in patients with indolent lymphoma. Because the presentation for patients with indolent lymphoma is not as stark and aggressive like the aggressive lymphomas. Patients typically do not have symptoms. Therapies that are given are not as highly intensive chemotherapy options. Watch and wait, you may have heard of it, is something that we very judiciously apply for our patients with indolent lymphomas. And then there's the third bucket called mixed lymphoma, wherein you have features wherein it can start off with a very slow-growing lymphoma, but then pick up pace and start behaving like an aggressive lymphoma. And one of the lymphomas that come to mind when I talk about mixed lymphomas is mantle cell lymphoma. When I talk about NHL subtypes, I will say that the majority of this pie belongs to diffuse large cell lymphoma. So 30% of patients have DLBCL, followed by follicular lymphoma, then CLL, then Burkitt, and then and less commonly, it is T and NK cell lymphoma. I'm sorry. Moving forward, clinical presentation of lymphoma, primarily patients present with enlarging lymph nodes, as you can see in the picture. Besides that, they can also have B symptoms. Now, B symptoms that we talk about in lymphomas are actually very specific. For example, patients have drenching night sweats. They have unintentional weight loss. They have fevers. Sometimes they can also present in a completely asymptomatic condition. They go for their annual physical workup. Their primary care physician does a CBC, and they come up with an elevated white blood count. Indolent lymphoma presentations are very, very different from aggressive lymphoma presentations. The one thing that I will say, if you can take away from this presentation, is that adequate biopsy is key. A fine needle aspiration is absolutely not right for patients to be diagnosed with lymphoma. And the reason for that is you can see individually, there are 3 types of biopsies that one can do. One can do a fine needle aspiration, one can do a core biopsy, which is basically a larger needle going in multiple times and taking in larger pieces of the tissue. Or one can do what we call an excisional biopsy, which is removal of the whole lymph node. Now, in the world of lymphoma, it is absolutely important to get enough tissue. And I will talk to you why that is so in just the next few minutes. But having said that, fine needle aspiration is just a few cells that we get under the microscope. We literally don't know what subtype of lymphoma we are dealing with, except for the fact that maybe it's a B or a T cell. And I just showed you that in patients with B-cell lymphomas, given that they make up for nearly 75% of the 85,000 non-Hodgkin lymphomas, we absolutely need to get a tissue that is adequate. So excisional biopsy is the gold standard, which means a complete removal of the lymph node. It definitely means surgical procedure, but it is typically something that patients recover from absolutely fine. But it's very, very important because you look at the entire architecture of the lymph node. Besides, we can actually do multiple tests, which I will go through in the next slide, and help you understand why that's important. Now, sometimes a lymph node may be deep in the abdomen, in which case it might actually mean an open surgery. And of course, we don't want our patients to go through morbidity. And that's why I think sometimes we are also okay with core biopsies, but we need a good tissue sample. So the one thing for my patients here who have a new diagnosis of lymphoma, you do want to ask your treating physician if the tissue that they got was enough to make a diagnosis. And if they do insist on getting more tissue, I would highly advise that you do get another tissue biopsy. So making the diagnosis and why it's really important to get a good tissue biopsy, like I said, an excisional is way more important than a fine needle aspiration, which is absolutely not good for lymphomas. But if you cannot get an excisional biopsy, a core biopsy is fine. I told you why that is so, because you take a look at the structure of the cells, whether they are small, whether they are large, whether they are cleaved, whether they are not cleaved. But besides that, we typically run 3 types of tests, which is why it's important to understand that the subtype of lymphoma impinges upon these 3 tests. The first is flow cytometry and immunohistochemistry. This is where we actually stain the tissue with multiple CD markers, and each subtype of lymphoma stages or stains differently. For example, patients with follicular lymphoma are typically CD20 positive, CD10 positive. On the other hand, patients with marginal zone lymphoma are CD20 positive, but CD5 and CD10 negative. Patients with mantle cell lymphoma are CD20 positive, CD5 positive, CD23 negative. So that really is really helpful in understanding the subtype. In order to aid that, we also have what we call cytogenetics of FRISH, which is basically looking at chromosomal abnormalities. For example, follicular lymphoma is enriched for a translocation called translocation 1418. On the other hand, when we look at molecular genetic studies, we do look at something like cyclin D1 as well as BCL2 for patients with follicular lymphoma. Let's talk about an initial evaluation. I think clinical medicine is here to stay, and therefore I do believe that a good history and physical is key. Laboratory evaluation absolutely helps, especially when it comes to complete blood count, to look at what your level of hemoglobin, platelets, what is your level of your white count, your kidney function, your liver numbers. There's a marker called LDH that we look at, and we really incorporate that in multiple prognostic indices, and that helps us understand how much of a high-risk lymphoma are we dealing with. But it doesn't mean that every elevation of LDH means that the lymphoma has become aggressive. Sometimes inflammation, infection can also cause elevation of LDH. Let's talk about bone marrow biopsy. Now, bone marrow biopsy used to be done historically for all lymphomas. However, with the advent of better radiographic tools, for example, PET-CTs, we are now able to see bone marrow involvement without having our patients to go through bone marrow biopsies. And that's typically true for patients with aggressive lymphomas. So at this time, when someone is diagnosed with lymphoma, we typically not only go through a lab evaluation, but we go through either a CT scan with contrast or a PET-CT. And sometimes a bone marrow biopsy is certainly part of staging workup, for example, in patients with chronic lymphomas, like follicular lymphoma, marginal zone lymphoma. But in aggressive lymphomas, like diffuse large cell lymphoma, Burkitt lymphoma, or for patients with Hodgkin, we typically no longer do bone marrow biopsies. So let's talk about the imaging studies that we now have for patients with lymphoma. All we had nearly 4 decades ago was chest X-ray. Then came the CAT scans. And CAT scans actually told us good information about the lymph nodal size, lymph nodal morphology. But really, PETs changed it all for patients with aggressive lymphoma, or what we call PET-avid lymphomas. So PET basically uses FDG or glucose dye, which goes into areas of high metabolic uptake. On your body, you normally have organs with high metabolic uptake, which normally light up black on a PET scan. So your brain, your tonsillar area, heart, your 2 kidneys, and the bladder, they are normally jet black when you get a PET scan. However, when there is a metabolically active tumor, it doesn't always have to be lymphoma, but aggressive lymphomas or FDG-avid lymphomas will also look black, as you can see on this PET scan. The difference between a CT scan and a PET scan is what I have shown on this diagram here, where you can see there is a large mass sitting right here in the chest. And when you look at the avidity of that mass, meaning the brightness, it is yellow. And that basically means that this is a highly FDG-avid, metabolically active process. And in this case, this patient had a lymphoma. So FDG PET is certainly more accurate when it comes to staging than CT scans for patients with nodal and extranodal lymphomas in about 40% of patients. As a result, FDG PET is routine for patients with FDG-avid lymphomas. That primarily encompasses Hodgkin, follicular, diffuse large cell lymphoma, T-cell lymphomas. On the other hand, it's not recommended for patients with low FDG-avid lymphomas. For example, CLL or marginal zone lymphoma, we do not do PETs because these lesions are not FDG-avid or metabolically active on PET. A PET scan is more sensitive than a bone marrow biopsy in Hodgkin lymphoma. Therefore, we no longer do bone marrow biopsies in Hodgkin. And typically, if I see bone marrow involvement on a PET in an aggressive B-cell non-Hodgkin lymphoma or an aggressive T-cell non-Hodgkin lymphoma, I typically don't do a bone marrow biopsy after that. So what is this FDG avidity and how does it actually look different? So you can see on the panel A here, this is a patient with a large mediastinal mass, so a mass in the chest. It's jet black. This is a patient of mine with Hodgkin. Then you have diffuse large cell lymphoma patient where they have a neck mass here, right here where my cursor is. And this is my patient with follicular lymphoma who has a mass sitting right around his abdomen as well as in his chest. And then we have patient here who has CLL SLL. He does have SLL. He does have bulky lymph nodes you can see in the armpit, but these are not FDG avid. As a result, we typically do not do PETs in patients with low FDG avid lymphomas. Now, why is a PET really important? Not only for initial staging for FDG avid lymphomas, but also to assess response. Previously, when we had the CT scans, we used to treat every patient till the lymph node went to 1.5 centimeter or under. As a result, even if there was no residual tumor, but the size was 2 centimeters, we kept on treating the patient, or basically called the patient a partial response. This is where PETs really came in handy, because a PET was really able to tell us if a previously FDG avid lymphoma is no longer FDG avid, which means it's no longer metabolically active. Sizes did not matter anymore. So someone who may have started with a size of 10 centimeter mass on a PET, which was jet black, at the end of treatment, if the avidity went away, meaning the blackness went away, but if the mass went down from 10 centimeters to 3 centimeters, we would actually call it a complete metabolic remission and stop therapy after 6 cycles, usually for aggressive lymphomas. And the way you may have seen it on your patient case reports or on your imaging reports to be noted is this term called Deauville. Deauville is basically a small village in France where a lot of specialists met and they looked over multiple ways of using a PET scan to assess whether someone is in response or not. And they came up with what we call the 5-point Deauville system. And the 5-point Deauville system really looks at the uptake in comparison to the pool in the chest and to your liver. And based on that, can ascertain someone to either be in a complete response, partial response, stable response, progression of disease. That's how we now evaluate FDG avid lymphomas. Again, this doesn't quite apply to patients where the lymphoma is not FDG avid, for example, marginal zone lymphoma or CLL. Now, I will say that I don't focus a whole lot on staging as my other lymphoma colleagues do, because I do believe lymphoma is a disorder of the blood. Blood is everywhere. We don't use the word metastasis in the world of lymphoma. It's not the same with regards to impact of outcomes like it would be in someone with lung cancer or breast cancer, meaning patient with stage 1 lung is curable, stage 4 is not, survival is bad. That rule doesn't apply to the world of lymphomas. Usually, if we look at patients with non-Hodgkin lymphoma who have, say, indolent lymphomas, nearly 85% of patients are going to have involvement of the bone marrow, involvement of an extranodal site, meaning the patient is going to be stage 3 or stage 4. On the other hand, in patients who have aggressive lymphoma as well, the reason staging becomes important is so that we can offer therapies accordingly. So for example, patient who has a limited stage diffuse large B-cell lymphoma, say stage 1, we do not need to do 6 cycles of chemotherapy. We can actually do away with 3 to 4 cycles of chemotherapy. On the other hand, if someone has stage 4 disease, we absolutely need to do the full 6 cycles. But I do not want my patients here to carry the burden of stage through their journey with lymphoma. A lot of you may be diagnosed with stage 3 and stage 4. It does not equate to the outcomes that you may have heard of with other solid cancers. This is a blood disorder. As a result, the way we treat it is extremely different, and staging is really not that important as it is in other cancers. There are certain modifiers that you may have seen in the notes of your physicians. For example, if someone has B symptoms, we actually say the patient has stage 1A or B. If someone has a lung involvement or liver involvement, meaning an organ involvement, we call it an extranodal site. Spleen involvement. Now, spleen is actually a giant lymph node, but it helps to know at the outset whether the spleen is involved or not. X means whether a patient had bulky disease. It's important primarily for patients with Hodgkin lymphoma, because if someone has a bulky disease, we may end up giving them more chemo, or we may end up consolidating their patient's response with radiation therapy sometimes. Now, what's the prognosis? Prognosis is a very tricky term, because I can tell you that patients who started off with a really good prognosis, they may have migration of prognosis as their disease evolves. And someone who may have very high risk disease at the outset, they may be completely cured. So it's not really, again, hugely important. It also doesn't tell us what to do for the patient. This is not a predictive marker. But prognosis certainly tells us if my patient is high risk or not. So, for example, there are prognostic indices called the IPI, which is the International Prognostic Index. And within multiple subtypes of lymphomas, there are very many variables that basically assign a point if a patient meets that point. So in CLL, you have what we call a CLL IPI. For follicular lymphoma, we have a FLIPI. For diffuse large cell lymphoma, we have a DLBCL IPI. For mantle cell lymphoma, we have a MIPI. So things like that actually help us at the outset, as well as the patients, to know what is their level of risk when they start, what do they need to get in order to get to good response, and what is their chance of staying in a good response. Moving over to the basic categories of lymphomas, I talked about their general rate of growth. So indolent lymphomas are slow growing. Sometimes, though, they can transform to an aggressive lymphoma, and in which case we have to manage them like an aggressive lymphoma. Let's now focus on the tools that we have and the many, many tools that have evolved as we treat our patients with lymphoma. So I will start off talking about watchful waiting. Now, watch and wait, and sometimes it's also called active surveillance. Sometimes it's called observation. It's a very counterintuitive word, because in one breath, I'm saying you have a blood cancer, and in the other breath, I'm saying let's not do anything about it. So it doesn't really fit well with what we know has happened over the years with regards to cancer. But time and again, in patients, especially the ones with indolent B-cell non-Hodgkin lymphomas, certain indolent T-cell lymphomas like primary cutaneous T-cell lymphomas, watch and wait is an absolutely fine tool to take care of patients. Watch and wait does not mean nonchalance. You still have to follow the patients. You have to follow them with an eagle's eye. You don't need to scan them every so often. We don't want to overscan, but we want to make sure we watch and wait so that they are able to live in harmony with their disease. And some of the subtypes of lymphomas where we can watch and wait without impacting their outcomes in the long run are lymphomas like CLL/SLL, follicular lymphoma, indolent mantle cell lymphoma, marginal zone lymphoma. These are some of the subtypes where watch and wait is absolutely justified. Very many clinical trials have been done where early treatment was compared to watch and wait, and there was no impact on patient outcome. So delaying therapy, provided you meet certain criteria, such as the lymph nodes are small, they're not interfering with organ function, blood counts are normal, you're absolutely asymptomatic. These are some of the parameters that we look for to say you're a good or not a good candidate for watchful waiting. So when do we actually say that it's, watchful waiting should come to an end? We should talk about therapy. That's when you start having abnormal labs. And that's not really a one-time abnormality. It has to be given a little more credence with regards to trending those blood counts. Usually, I would say a hemoglobin of 11 or under that is slowly trending down over time, or platelets of 100,000 or under, B symptoms that are just worsening with time, sudden development of increased large lymph nodes that are causing a lot of swelling, tenderness, sometimes even organ dysfunction. Elevated LDH, calcium are some of the signs where I get a little more worried about the possibility of slow growing lymphomas becoming slightly fast growing lymphomas. I think these are some of the times where I say we should stop the watch and wait and we should start talking about treatment. In terms of what is the next tool that we have besides the watch and wait, so when we actually start talking treatments, I will say in the world of lymphomas, a lot changed once we had antibody therapies. This is chemotherapy free. There is no chemo involved. And rituximab was the first antibody that was actually deployed to kill lymphoma cell. So what is antibody therapy? So we all have antibodies. And what is the function of the antibodies is to fend off germs, to basically help us recover from infection or to prevent having clinical symptoms of infection. So that was actually used by scientists as a tool to target lymphoma. We know that certain proteins are expressed on lymphoma cells. You remember we talked about the CD markers, which is why the diagnosis is so important because subtypes are different based on the different CD markers. B-cell non-Hodgkin lymphomas express CD20. It's a protein that sits on lymphoma cell. So technically, if you were to develop an antibody, genetically engineer them, then these antibodies, when infused into the system, they can latch on to the lymphoma cell that expresses CD20 and cause destruction of the lymphoma cell. And that is how rituximab really came into the fore and it changed the outcomes of B-cell non-Hodgkin lymphoma. At this point in time, patients with B-cell non-Hodgkin lymphoma can either be treated with, can be offered therapies with single agent rituximab or maintenance rituximab. Usually therapy for low-grade indolent lymphomas like follicular, marginal, sometimes CLL is just rituximab alone. Usually for aggressive lymphomas, we typically combine chemotherapy with rituximab. That is called chemoimmunotherapy. So rituximab is immunotherapy. It uses your immune system to tackle the lymphoma. Maintenance therapy is a concept that we frequently use in patients with slow-growing lymphomas. The idea behind maintenance is maintaining a remission. So if someone has achieved a good remission with therapy, many trials have explored continuing rituximab as maintenance in order to improve the remission. Now, there are many debates in the field, and one of the debates is about offering maintenance versus not. In the world of lymphoma, if anything improves overall survival, meaning our patients live longer, it becomes standard overnight. And maintenance therapy post autotransplant in patients with mantle cell lymphoma has shown to improve survival. And that's why that is considered standard if someone goes through an autotransplant for mantle cell lymphoma. However, outside of that, whichever study you look at, for follicular lymphoma, for marginal zone lymphoma, for diffuse large cell lymphoma, maintenance therapy improved what we call progression-free survival, meaning your chance of being in a remission is longer, but it does not translate into a patient living longer, which means that you could potentially debate it out and say, why give patients maintenance therapy if the survival is not improved? When they need treatment, they will get on treatment at a later period of time. And the pro to that is we should offer maintenance because if we are able to keep the patients in remission longer, then why not? So I think that debate will continue in our field. And I will say, I think it's a conversation. And I have swayed both ways based on patient preference. As a result, it's absolutely important to discuss the pros and cons of maintenance rituximab therapy or maintenance antibody treatment. Now, since we have antibodies, we can potentially use them in various ways. So like I talked about, using it against a target, which is expressed on lymphoma cell, which is CD20. So there is rituximab. And then subsequently, there has also been an antibody, which you may have heard of, called obinutuzumab. Obinutuzumab is an antibody that has been used in patients with CLL, has been used in patients with follicular lymphoma. On the other hand, what else could you do with this strategy? So if you make an antibody, could you deliver chemotherapy with that same antibody into the lymphoma cell and thus spare the normal cells of any damage? And that is where antibody drug conjugates came into fore. And one of the most important ones, I would say, is brentuximab. Brentuximab is an antibody drug conjugate where you can see on the right here, this is the antibody. And if I go back, this is the antibody. And attached here is a linker. And to this linker is a chemotherapy molecule called the cytotoxic agent. So as you may imagine now, you can typically target this antibody against a particular lymphoma cell. Brentuximab targets against a cell that expresses CD30. Hodgkin lymphoma cells, T-cell lymphoma cells express CD30. And they basically latch on to that lymphoma cell and then deliver the chemotherapy only to the lymphoma cell and spare the agents of normal cells of any kind of side effects. Sometimes there can be bystander effect, but for the most part, this is an extremely efficacious way of targeting cellular death of lymphoma. Similarly, you may have heard of polatuzumab. Polatuzumab is a target that tackles CD79, and polatuzumab has actually been used in patients with diffuse large B-cell lymphoma. So let's talk about chemotherapy. I think we are not completely still in the chemo-free world, especially when it comes to aggressive lymphomas. Aggressive lymphomas have a chance of a cure. As a result, chemotherapy over the last several decades has shown to cure patients with aggressive lymphomas. As a result, we have to be very mindful about jumping into chemo-free agents, but usually we have made substantial progress even with that regard. We all want to get away with chemotherapy at some point. However, we want to do it well. And I can tell you that in patients, say with mantle cell lymphoma, there is a lot of research that is being done to limit chemotherapy by using chemo-free strategies. But for the most part, we still do deliver chemotherapy. Not all chemotherapy is intense. For example, you may have heard of something called bendamustine rituximab. It's a chemo that's actually very, very quality of life friendly. Patients typically don't lose hair. They don't have a lot of nausea. Their counts usually stay stable. But bendamustine rituximab is not efficacious in highly aggressive lymphomas like diffuse large cell lymphoma. As a result, for those lymphomas, R-CHOP or R-EPOCH is something that we continue to use. But there is good news there because there are certain antibody drug conjugates that have been tested in clinical trials that are looking very promising. So R-CHOP in diffuse large B-cell lymphomas may no longer be the standard of care. We are actually awaiting FDA decision. Similarly, in Hodgkin lymphoma, for years, we used to give a chemotherapy called ABVD for patients with stage 3 and stage 4. With the advent of brentuximab, the B was replaced with A, which is Adcetris or brentuximab. AAVD was shown to be superior as compared to ABVD, which is the historical standard for Hodgkin, not only with regards to progression-free survival, but also with overall survival. So patients are living much longer if we were to give them AAVD if they have stage 3 or stage 4 disease. So I think things are definitely happening, which are looking very, very attractive, and research continues to happen in the form of clinical trials. All of these agents that I'm talking about, they came out of clinical trials. As a result, we actually believe in the power of science, and that's how we are here where we are in the world of lymphomas. FCR is a chemotherapy that used to be used in patients with CLL if they were younger. I will say I have not given FCR in CLL. I've not given chemotherapy for patients with CLL at least for the past 7-8 years, because we have a huge onslaught of multiple chemo-free targeted agents, which I will talk about. So talking about these targeted agents, what are they targeting? I talked about these switches that have gone awry in lymphomas. We have now been able to identify some of these switches in certain types of lymphomas that are making the lymphoma get more proliferative or faster growing. So technically, if you can inhibit that switch, you typically can cause the lymphoma to either die or the lymphoma to grow very, very slowly. And one of this switch is what we look at in terms of the B cell receptor signaling pathway. So technically speaking, this is a B cell receptor. Anytime an antigen, so say a cancer antigen like CLL, sits on it, it triggers multiple signaling pathways. One of the signaling pathways that has shown to have huge promise and change the landscape for patients with lymphoma is what we call a BTK inhibitor. Initial one called ibrutinib. Ibrutinib was first studied in 2011, later FDA approved in 2014 for patients with CLL. And these patients who historically succumbed to chemotherapy now started living with their chronic lymphocytic leukemia and living very well. So targeted agents are here to stay. Now our next mission is to make sure that these targeted agents don't cause a lot of toxicities. And with that in mind, ibrutinib was later followed by what we call second generation targeted inhibitors like acalabrutinib, zanubrutinib, the premise being that they are all equally efficacious, but there are patients, about 30%, who may have nagging side effects with ibrutinib. And those side effects are mitigated by using acalabrutinib or zanubrutinib. These names are a mouthful, but I will say that each one of these drugs has definitely changed the course of lymphomas. Let's now talk about immunomodulators. So lenalidomide is one of the front runners of immunomodulators. The way this drug attacks lymphoma is not like chemotherapy. Chemotherapy kills the fastest growing cells of your body. So the cancer cells die, but at the cost of normal cells. And lenalidomide here actually works on the immune effect. It works on B cells, NK cells, which are natural killer cells. It works on the T cells. It basically makes the environment or the microenvironment around lymphoma cell less conducive for survival. Lenalidomide is an extremely efficacious agent, and you may have heard of it in patients with follicular lymphoma, marginal zone lymphoma, mantle cell lymphoma. It can have some side effects, but they are very absolutely manageable. Now let's talk about venetoclax. So BCL2 inhibition, BCL2 is another signaling pathway, and it's basically called the death cascade. So basically, venetoclax inhibits BCL2, and because of that, the CLL cell dies. Venetoclax is an oral tablet, just like ibrutinib, and venetoclax again showed excellent efficacy in patients with CLL. At this point in time, for patients with CLL, there are now completely chemo-free options where they need to require therapy. And at this point, the discussion is actually between a BTK inhibitor or a BCL2 inhibitor. Venetoclax has also been explored in other subtype of lymphomas with promising results. Now let's focus on immunotherapy that has evolved over the last 6 to 7 years. And of course, you have heard of checkpoint inhibitors. You may have heard of CAR T cell therapies. You may have heard of bispecific antibody treatments. It's really difficult to go over individual therapies in detail because each of these could be 1.5 hour lecture. But having said that, I think I just want to give you a flavor of what is going on in this field. And I'm just it's so gratifying to be a physician in this era because we have so many options that are actually so promising. So let's talk about immunotherapy. Immunotherapy, to keep it simple, immunotherapy basically is medication that uses your own immune system to fight off cancer. Which immune cell we may choose to do that depends on which drug we use. For example, we may choose to target B cells, and then usually it can cause cellular death, or we may choose to activate your fighter cells, which are your T cells, to cause lymphoma cell death, because in patients with lymphoma, most of the times the T cells, which are your fighter cells, they have forgotten to really fend off lymphoma. They've forgotten to recognize lymphoma cell as foreign. So immune checkpoint inhibitors, CAR T cell therapies, these are just some of the many ways of reinvigorating your own fighter cells to be able to destroy lymphoma. So immune checkpoint inhibitors probably were the first front forerunners to be able to do or make an impression and impact on lymphoma and lymphoma death. And I will say pembrolizumab, nivolumab were the front runners. And these are immune checkpoint inhibitors that have been used with rip-roaring success in patients with relapsed Hodgkin lymphoma, in patients with NKT cell lymphoma, in patients with brain lymphoma, testicular lymphoma. So the concept is that there are proteins, PD-1, that sits on T cell, and this PD-1 binds to PD-L1 on the tumor cell, and as a result, the T cell gets hushed and it does not do its job, which is killing the tumor cell. What do these checkpoint inhibitors do? They basically bind to the PD-1 on the T cell. As a result, PD-1, PD-L1 cannot bind to each other, and the T cells now cause activation, and thus they will go ahead and cause cellular death. So in terms of the responses, this is called a waterfall plot. This is the baseline, and every bar here is a patient. So if you have any bars that go up, that means the patient did not respond. You can then see that on this data with pembrolizumab, each and every patient responded, whether they had a complete response or a partial response, but these were heavily pretreated patients, and they all responded to checkpoint inhibitors. So clearly this is a winner on hand. As a result, it has been brought forward in testing. And at this point, it's actually being tested and completely enrolled in an intergroup study called a SWOG study, wherein AAVD, which is now the current standard for Hodgkin lymphoma, is head-to-head being compared with AVD and nivolumab. So the results will probably be expected in a few years, but the enrollment has completed. We actually had that study open at our site, and patients did very well. So in terms of the next stage for immunotherapy, I think chimeric antigen receptor T cell therapy has really made the biggest impact in my mind. And it has really helped a lot of patients not only survive, but survive well without lymphoma. And previously they had no options. So I think chimeric antigen receptor T cell therapy is here to stay. But the whole idea is to basically genetically engineer a product using patients' own T cells and be able to recognize and make a product in such a way that it has a domain up here that can target a lymphoma cell. The CARs, or chimeric antigen receptor T cell therapy that we currently have approved, targets a protein called CD19 on the lymphoma cell. So this is the antigen recognizing site. This is the transmembrane domain, which is connected to the signaling molecule that activates the patient's own T cells. So basically, the idea is to take patient cells, and that process is called apheresis, take it to a lab wherein we isolate the patient's T cells and make them CAR T cells. So basically, super fighter cells. So these T cells now, imagine having an antenna which is now able to recognize lymphoma cells as foreign. We then multiply them and then subsequently infuse them in the patient. And these T cells now unleash upon the lymphoma and cause lymphoma cellular toxicity, or as we call lymphoma cell death. There are 3 CAR T cell therapy constructs that are currently approved for patients with aggressive large cell lymphoma. 2 of them have been approved for follicular lymphoma. And another CAR T cell therapy has now been approved for relapsed mantle cell lymphoma. In terms of toxicities, typically, CAR T cell therapy does not have the chemo-related toxicities. What it may have is that CAR T cell therapy typically causes cellular death by hitting on the CD19, that's a B cell. Now, you also have normal B cells. As a result, patients can have, up to 30% of patients can have a higher predisposition to developing infection. The other toxicity that the CAR T cell therapies can have is something called cytokine release syndrome, wherein basically as they unleash upon the tumor, it causes a milieu of inflammatory mediators, and these can look like low blood pressure, high fever, or respiratory distress. All of these are manageable. They're reversible 95% of the times. We have antidotes, we have steroids, but these are toxicities that we had to learn over the last 4.5 years. Neurological toxicity is something that can also happen with CAR T cell therapy, albeit rare and less common than CRS. And neurological toxicity is also reversible, but it's important to recognize it, that this is one of the unique toxicities of CAR T cell therapy. In my mind, I think the economic toxicity is real. CAR T cell therapy is a $500,000 product. Insurance companies authorize it now, but at some point, someone is bearing the burden of it. As a result, I think CAR T cell therapy is the first iteration of immunotherapy, in my humble opinion, and I think there are just very many constructs out there being tested in clinical trials wherein maybe the efficacy is just as high or even higher, the toxicity is lower, and the economic burden, because the manufacturing takes that long and it's so specialized and unique, may not be as high as we have with the current constructs. This is one of my patients who had failed 7 lines of therapy. This patient had relapsed diffuse large B-cell lymphoma. He enrolled on one of the CAR T-cell therapy studies that I had 5 years ago. And you can see on his PET that this 20-centimeter tumor completely melted away, and he had a complete response. So at this point in time, these are called Kaplan-Meier curves. What they actually show, each of this is a patient or multiple patients, and when it dips, it means a patient relapses. So technically, when you have a straight line that you see, you know that at some point the patient stopped relapsing. So with CAR T cell therapy, we actually were able to show that with the 3 constructs that are now FDA approved, we were able to show that at least 45% of patients at the 5-year mark did not relapse after receiving CAR T cell therapy. 45% of patients that could have historically not had any other options now do have CAR T cell therapy, but it also means there is more work that needs to be done, because now the new, I would say, unmet need is patients who fail CAR T cell therapy. So there are multiple other agents that are definitely being investigated, but CAR T cell therapy previously was, when it wasn't approved, it was tested on the clinical studies. When it showed these excellent responses, the algorithm was changed, which meant that initially when someone with diffuse large B-cell lymphoma, if they relapse, they typically get a second line of chemo. And if they respond, they go to an auto transplant. There are patients who fail an auto transplant, and at that point, they had no options. But with the success of CAR T, In patients who couldn't go to an auto or who failed an auto, they could now be taken to CAR T cell therapy, wherein about 45 to 50% of patients could be salvaged. So clearly, the next iteration of trials had to be a comparison of CAR T cell therapy versus an auto transplant. And that's when there were 3 randomized trials, and 2 of which showed a benefit of CAR T cell therapy over auto transplant. So now, for patients who have an early relapse with diffuse large cell lymphoma, we typically take them straight away to CAR T cell therapy. If they have not had an early relapse, meaning within a year, they have relapsed at the 2-year mark, there is still good data to believe that they could get a second chance at a cure with an auto transplant. So clearly, the algorithm keeps moving up, and there are some clinical studies that are actually also looking at CAR T cell therapy in the frontline setting. So stay tuned for that, but I will say most of this success is attributed again to a lot of clinical trial research and of course to patients who trust in the research. I think the biggest impact that has been made over the last 1 year beyond CAR T cell therapy is what we call bispecific antibody therapy. What it is basically it's an antibody with 2 prongs. One prong will sit on a lymphoma cell, and the other prong will basically sit on a T cell, which is your fighter cell, and it will tell the fighter cell, which is the T cell, to kill the lymphoma cell. So this is a little different from CAR T cell therapy because, as you know, CAR T cell therapy is where we use patients' own T cells and engineer their T cells to make them CAR T cells in a lab and then infuse it back. Bispecific antibody therapy has the advantage because it's an off-the-shelf product. These are antibodies available with these 2 prongs, wherein after infusion, the job is to activate T cells. So it cuts away manufacturing time, and there has been a lot of promise with multiple BiTEs, as we call them, BiTES, so bispecific antibody therapies. You may have heard of names like mosunetuzumab, epcoritamab, glofitamab, and at this point, mosunetuzumab is approved for patients with follicular lymphoma, and we are absolutely awaiting approval on epco and glofi for patients with diffuse large cell lymphoma or follicular lymphoma. So I think the options are certainly improving, they are becoming very many, and this is just a win-win for all of us. The other concept that you may or may not have heard of is something called minimal residual disease detection. Right now, the tools that we have to detect if someone's lymphoma is responding or not is a scan, then be it a PET scan or a CT scan. And it is basically a gross presence or absence of lymphoma based on certain criteria that we use. But being that this is a blood disorder, we do know that patients who relapse may actually have a clinical remission, but they may still have clones that may be harboring in their blood, which means they may not be in a molecular remission. So now the idea is to really get to a level of disease detection where we can identify if the patients have actually gotten to a molecular remission, track the disease, and at the first chance of relapse, hopefully target the disease so that a clinical relapse doesn't happen. Now, this is clearly an idea that, of course, looks so promising, but at this point is not ready for prime time. And there are many, many assays, as we call it, to detect minimal residual disease. But I will say of the many subtypes of lymphomas where we have begun to use minimal residual disease detection, or MRD, it is mantle cell lymphoma and CLL. We are hoping to use it in follicular lymphoma. We are hoping to use it in diffuse large cell lymphoma, but we are actually awaiting clinical trial results. At the end of the day, the idea is to really not treat everyone with a one-size-fits approach. I hope that personalized lymphoma therapy continues to gain momentum, and we have made huge progress even compared to a decade earlier. And at this point, like I said, it's the first thing to do is to get a good biopsy, to be able to really ascertain what is the type of tumor that we are looking at, what is the pathway analysis, signaling pathway that's being activated, maybe targeted a little different, and realizing that all of this can only be successful if this is done within the context of a clinical trial. So I will say key questions that you should ask your doctor is, what is the subtype of lymphoma that I have? The biopsy that you got, was it enough or do you need more? And why do you need more? What is the information that you're looking for? What are my treatment options? What are the goals of therapy? Is it curative, meaning are we going with intensive chemotherapy because there is a chance of a cure? Or are we not, because the idea is to live with the disease in harmony where you're able to have a good quality of life? The goals have to be discussed with your doctor. Very, very important to really look at any clinical trials that you may benefit from, whether in the frontline, meaning untreated, newly diagnosed lymphoma setting, or the relapse setting. And it really never hurts to see an oncologist who only sees lymphoma. They do have another lens because all they see all day long is lymphoma. And I will say it can get a little overwhelming when someone is diagnosed with lymphoma. And I will say this is where LRF is your one-stop shop. And I feel like a lot of my patients, I feel a sense of relief because they have a friend in LRF. You really have to give them a call and say, I am looking for clinical trials. I live in this area. Do you know which center might offer clinical trials in this subtype? Or I'm looking for a lymphoma expert that I can go see in this area. Do you have any suggestions? There are also multiple forums like these where many, many lymphoma experts have given their personal time to educate patients, to talk a little bit more. There's, of course, our annual North American forum that just got completed. It's usually in the fall, that I would highly encourage each of you to attend, wherein there are 2 full days dedicated to lymphoma. Each of these are divided into multiple subtypes of lymphomas and a lot of information that is actually provided at those sessions. So with that, I leave you with a lot of hope. I will tell you that the field is rapidly evolving. Many novel therapeutics are underway, already approved. Some of them are waiting approval. They're all chemotherapy free. LRF has a wide range of resources, so please, please use them. We are here for you. So please make sure that you really reach out to us. And I will tell you that huge advances are really anticipated in the foreseeable future. And on that note, I will end today's talk, and I'll be happy to take some of the questions.
Thank you so much, Dr. Kamdar. And as you mentioned, we're just going to jump into the Q&A portion of the program. We've already received quite a few questions, but please do continue to send those into the Q&A box to send in any questions that you might have. But we're going to start with a question that was sent in before the program today. This patient is wondering, when treatment-naive patients on watch and wait are prescribed venetoclax and obinutuzumab as a frontline therapy, can they repeat the same therapy when they relapse, or are they typically prescribed a BTK inhibitor?
So I think this is a great question. I think the patient in question may be a patient with CLL, because that's where venetoclax and obinutuzumab is typically given for a total of 12 months. If you do achieve a remission, or if you end therapy, and when you do relapse, or if you relapse, I think there is good data that is emerging around venetoclax retreatment options. Now, if someone stops in December and relapses in Jan, I might think a little bit about it to retreat them with venetoclax. But I think it's a very valid alternative. At the same time, switching to a BTK inhibitor is also a valid alternative. Basically highlighting the fact that both of these molecules are very efficacious.
Okay, thank you. And this next patient submitted this question when you were kind of discussing the difference between aggressive and indolent lymphomas and just subtypes in general. And they're wondering, where does T-cell large granular lymphocytic leukemia fit into that chart?
So it actually does fit under the T-cell lymphoma bucket. And these are lymphomas that can stay fairly indolent and usually are very treatable with options such as oral methotrexate and many others.
Okay, thank you. And next patient writes, I was diagnosed with MCL about 2 years ago. And since then, I've been in watch and wait with my doctor at Dana-Farber. But this week, after having my blood tested, everything was back to normal. I asked my doctor if this is normal, and he said this occurs in about 5% of cases. Of course, I'll stay in watch and wait, but my question is, do you think it will stay in remission or will it come back with a vengeance?
So I think, watch and wait certainly is an absolutely reasonable option for patients with mantle cell lymphoma. And some of the data with watch and wait came from Weill Cornell. Peter Martin was the first author, and he actually looked at many, many patients with mantle cell lymphoma who he could safely watch and wait. And if my numbers serve me correct, I think 30% of patients were able to watch and wait for over 5 years, and the remaining had to be treated at some point. So at this point in time, I will say that it's a very reasonable plan to continue watch and wait. I have had many patients like you who have been on watch and wait and who continue to be on watch and wait. In terms of your question of whether it'll ever come back with a vengeance, usually if you're on watch and wait, you're with a very keen, watchful eye. And I will say there are many early signs where the mantle cell lymphoma may be picking up pace. So that's exactly when you catch it and when you begin treatment.
Okay, thank you. This next patient has a question about symptoms. If there are strong B symptoms, such as fever, weight loss, drenching night sweats, and fatigue, is this automatically considered indolent?
So this is something that I think my patients with indolent lymphomas can certainly struggle with, because they are time and again told that they have a chronic lymphoma, but they do have B symptoms. And I would say that if the B symptoms are severe, it doesn't mean that the indolent nature of the lymphoma has changed. It probably means that it may be time to start treatment. But remember, B symptoms alone can be fairly non-specific as well. Like someone can have an infection and you can still have drenching night sweats. Someone can have a really low thyroid level and you can have severe fatigue. So again, B symptoms is primarily fever, weight loss, and drenching night sweats. Fatigue is not a part of B symptoms. But having said that, it doesn't mean it's no longer indolent. It is still considered indolent, but it may be time to talk about treatment.
Okay, thank you. And this next patient is wondering if there is a targeted treatment that you know of for PTCL TFH.
So I think both of these questions are with regards to TFH. I think this is a very nuanced lymphoma, I will have to say. For example, there are multiple PTCLs that, as I said, the ALK positive anaplastic large cell lymphoma, ALK negative anaplastic large cell lymphoma have a huge expression of CD30. So that's where targeted chemotherapy like brentuximab is now standard of care. There are certain PTCLs that may express CD30. There are many other targeted agents such as azacitidine, romidepsin that have been also explored. I will say that it definitely is a discussion that you need to have with your oncologist. And usually I will say that will determine what the next steps would look like.
Okay, thank you. And this next patient is wondering if you know of any updates or work being done for Waldenstrom patients.
I think there's a lot that is going on for Waldenstrom's patients that all looks very promising. Just like with ibrutinib changing the face of CLL, ibrutinib actually also helped a lot of patients with Waldenstrom's. And then subsequently, acalabrutinib, zanubrutinib has been tested in Waldenstrom's. Venetoclax is beginning to show a lot of efficacy in patients with Waldenstrom's. Having said that, there is a lot of research, especially coming out of Dana-Farber, where they're looking at other molecules. Say, for example, patients who have failed, who have not responded to chemotherapy, who have progressed on ibrutinib, who have now progressed on venetoclax. They need the options, and a lot of clinical trials are focusing on that.
All right, great, thank you. And the next question here is, how is SLL different from CLL in treatment?
So they're not different at all. CLL and SLL are basically synonyms. CLL means that the involvement is in the blood, primarily with a white count that's elevated. SLL is where you have a lymph node that stains like CLL, SLL. Usually, if someone has an elevated white count, they will eventually have lymph nodes. So a lot of times we talk about patients having a diagnosis of CLL/SLL. They mean the same thing. As a result, therapies are actually very similar. Same.
Right, great, thank you. We do have one question here. That's, how does positive PPD tuberculosis impact treatment options?
So I think a lot of us have been in developing countries where we have had BCG as a vaccine. As a result, we typically do have a positive PPD. And sometimes it can cause, when you have patients who get immune suppression with chemotherapy, it could potentially reactivate a latent virus. And therefore, infectious disease needs to be consulted. Usually a quantiferon test is what we typically go with. That's the gold standard to help us identify whether it's a true positive or not. And usually it means we watch the patients very closely, make sure that they don't get infected during chemotherapy, give them antibiotics, antiviral medications during that.
Okay, thank you. And we have a question here that this patient's doctors regularly check their CBC during chemotherapy for lymphoma, and I think they're wondering what indicates progress.
So in patients who are on watch and wait, I assume this patient is on watch and wait. We typically, when we take a look at the blood counts, we are looking at your CBC, wherein we're looking at your white count. Has it gone down to a point where you now are considered neutropenic, meaning a neutrophil count of 1,000 or under? Hemoglobin level to make sure you're not becoming anemic, and platelet count to make sure that you're not having low platelet counts. Besides that, we look at a comprehensive metabolic panel where we typically look at LDH. We look at making sure that your kidney function is doing well, your liver numbers are doing well. So these are some of the things that aid us in assessing how you're doing on paper. But of course, the rest will come based on whether or not you're having symptoms and what the physical examination shows.
Thank you. And next up is, my wife was recently diagnosed with classical Hodgkin lymphoma with a mass. Is first line of treatment typically ABDV chemo, or are there other treatments?
So in patients who have classical Hodgkin lymphoma, for stage 1 and stage 2, ABVD continues to be the standard, although there are many trials that are exploring AAVD. For patients with stage 3 and stage 4, especially if they are not older than 65 or 70, I would say AAVD is the new standard. And for older patients who have advanced stage Hodgkin lymphoma, I would still do AAVD, but with a lot of caution, because any chemo in that age group can cause toxicity.
Okay, thank you. And can you explain the difference between MRD and molecular remission?
They actually mean the same thing. So at this point, if you're looking at MRD, minimal residual disease, versus molecular remission, sometimes doctors may use the word molecular remission by looking at moleculars such as cyclin D1 on your MCL. But at this point in time, I will say when you're looking at this deep level of remission, you mean minimal residual disease.
Okay, thank you. And this next patient writes that they've recently been diagnosed with CLL and they're in watch and wait. They're looking for any general advice for them.
I think for patients with CLL, general advice would be to stay up to date on vaccinations, such as the flu shot, pneumonia shot, shingles series, COVID boosters. It's extremely important to get you a dermatologist because patients with CLL are at a slightly higher risk of developing curable skin cancers. So it's important to have an annual dermatology follow-up wherein you are able to be seen out head to toe for any suspicious moles. Make sure that when you go out in the sun, an SPF of 50 or over is used. It's important to stay healthy with regards to making sure that you're ambulatory, exercising well. Besides that, I would say eating in moderation, having a healthy lifestyle never hurts anyone. And then last but not the least, when it comes to CLL, there is a slightly high chance of developing infections. And that's why the need to stay up to date with vaccinations. When it comes to vaccination, we typically advise against live virus vaccinations. So any dead virus vaccines like COVID, flu, pneumonia, the new shingles shot, all of these will be something that will be recommended. And then last but not the least, I would say PCP visits to make sure all the age-related surveillance testing is done, like colonoscopy, prostate checks. These are some of the things that you have to stay up to date.
That's great. Thank you so much. And sticking with the topic of CLL, what is the advantage of using zanubrutinib instead of acalabrutinib other than having less side effects? Is it more effective?
I don't believe that zanubrutinib and acalabrutinib are different with regards to efficacy. I actually think ibrutinib, zanubrutinib, and acalabrutinib are all equally effective, but the toxicity profile or the side effect profile is different. I do believe that some of the issues with regards to, say, abnormal heart rhythm was seen in about 10% of patients with ibrutinib. It's down to 2 to 4% with acalabrutinib and zanubrutinib. I don't really have a preference between acalabrutinib and zanubrutinib. In fact, zanubrutinib just got approved for CLL as well. So at this point in time, I believe they're equally efficacious.
Okay, thank you. And looks like this will be the last question unless more pop in. But this patient writes that I received remission early in the 6 chemotherapy treatments I received. I continued with the 6 treatments because of the stage of my large B-cell lymphoma. Is that a positive response? I am now on a watch every 3 months for 1 year.
I think you are in a complete metabolic remission after completion of 6 courses of chemotherapy. The likelihood of staying in a remission is very high. Having said that, you definitely have to continue to follow up with your physicians. And I think what is suggested to you is considered standard of care. So I do that in my practice as well.
Okay, thank you so much. And I just want to thank you again for your time today. And of course, thank you to everyone for joining today's program. We hope that you found the information to be informative and hopeful as well. Please remember, if you have any additional questions, or if you'd like to be connected with someone else who's been impacted by lymphoma, or if you'd like to hear about our future programs, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments just to complete that evaluation because they are so important to ensuring that our programming is meaningful to you. And with that, I would like to thank you all again for joining us today. And thank you again, Dr. Kamdar. It was an excellent presentation.
Thank you so much. And I hope this was helpful to all of you. Thanks a lot. Have a
Have
good
a
day.
great rest of your day. Take care.